This lecture will cover acute kidney injury and metabolic acidosis. Here are the learning objectives, along with recommended reading. So to begin with, if I were to ask you what the definition of acute kidney injury is, could you tell me? Well, there are actually about 100 different definitions out there, and it depends on what study you look at. However, in clinical medicine, we typically use the KDIGO criteria, which is basically a combination of the acute kidney injury network classification along with the rifle criteria. And these have been joined together to form the KDIGO criteria, which stands for Kidney Disease Improving Global Outcomes. There's 3 basic measures within this. It includes a creatinine increase greater than or equal to 0.3 within 2 days, a creatinine increase greater than or equal to 1.5 times the baseline creatinine, or a urine output less than 0.5 mLs per kilogram per hour for 6 hours. Now you'll notice the first 2 criteria are bolded because this is what you'll primarily be able to find out on a patient when they present with acute kidney injury, as most patients don't actually measure their urine output at home to give you the 3rd criteria there. Another way to further define the acute kidney injury is whether they are oliguric or forming less than 400 mLs per day of total urine output, or non-oliguric, where they're forming greater than 400 mLs per day of total urine output. Now, I'm sure you already know this, but the kidneys gradually deteriorate with aging. This is normal, and typically you'll see elderly patients with at least stage 1 to 3 disease. This is defined by their GFR level, as you can see to the right of this graph. Typically at stage 4, which is a GFR less than 30, this is when you'll start preparing them for hemodialysis. And at stage 5, this is when you highly consider dialysis. Typically at stage 4 is when you really need to have a nephrologist on board. There are tons of causes of acute kidney injury. However, the easiest way to break this down is to determine whether the cause is pre-renal, intrinsic or in the kidney, or post-renal, or after the kidney. Pre-renal causes include causes such as volume depletion, think of GI losses or hemorrhage or burns, or decreased cardiac output such as heart failure, acute coronary syndrome, or massive PE. Also systemic vasodilation, such as what occurs in sepsis, anaphylaxis, or in anesthesia given during surgery. Also, it could include like intrarenal vasoconstriction, such as what you see in NSAIDs, or it could be efferent arterial vasodilation, which is what you see with ACE inhibitors and ARBs. Intrinsic causes include diseases such as acute tubular necrosis, which is further broken down into either ischemic or prolonged pre-renal acute kidney injury, drug-induced, such as what you would see in vancomycin use or IV contrast or NSAIDs. And remember, I also said NSAIDs for pre-renal, so it can cause pre-renal and intrinsic disease. Also pigments, such as rhabdo or hemolysis. You can also see acute interstitial nephritis as a common cause of it. Well, not common, but it can cause intrinsic disease. This is typically either drug-induced, such as cephalosporins, penicillins, fluoroquinolones, sulfa drugs, NSAIDs, PPIs, diuretics. Lots of different drugs can cause this. It could also be infections, such as pyelo, Legionella, TB. It could be autoimmune, such as Sjogren's or SLE or sarcoidosis. It could be malignancy, such as lymphoma, leukemia. Multiple myeloma can cause it. It could be glomerulonephritis. It could also be acute vascular syndrome such as renal artery stenosis, atherosclerotic disease, or it could be intratubular obstructions such as paraproteins that you see in myeloma or crystals with various drugs. Post-renal is a little bit easier to understand. If it's upper, it's typically like nephrolithiasis or blood clots or like external compression from a tumor, say in the colon or something that's pressing on the ureter. Or it could be lower, such as BPH or blood clots once again, or a urethral stricture. A few little fast facts to memorize though. Pre-renal and acute tubular necrosis causes around 75% of all cases of acute kidney injury, and ATN is the most common cause you'll see in hospitalized patients. When you're working up acute kidney injury, it's important to look at their history and physical exam. Their history, you need to review their medications. Are they on any diuretics or NSAIDs or other over-the-counter medications? Are they on an ACE inhibitor or an ARB? Did they recently get any IV contrast for a CT study? Do they have any predisposing conditions for acute kidney injury, such as underlying diabetes or coronary artery disease or peripheral vascular disease? Do they have any urinary obstructive symptoms? Physical exam, you need to look at their volume status. Do they have peripheral edema or RALs in their lungs? Do they have any systemic illness that might impair their kidney function, such as sepsis or DKA? Do they have any evidence of urinary obstruction? Just like in history, on physical exam, they may be tender over their bladder or have CVA tenderness or something that might indicate an infection. As far as diagnostics go when you're working up acute kidney injury, the diagnostics should never supersede your clinical intuition. You always have to look at the patient clinically and not just rely on labs. But you should always consider getting a CBC, looking for a white count to rule out infection or inflammation, or anemia, which could be a common cause of ATN. You'll obviously want a basic metabolic profile to assess their electrolytes and renal function and to determine if the patient has any metabolic acidosis. You'll want to get a BUN to creatinine ratio. This is just a simple calculation you do from the basic metabolic profile where you take the BUN divided by the creatinine. In pre-renal acute kidney injury, the kidney responds by reabsorbing urea, sodium, and water, often resulting in a BUN to creatinine ratio greater than 20:1. So remember, pre-renal acute kidney injury, greater than 20:1, which we covered in the heart failure lecture also. Whereas a BUN to creatinine ratio less than 20:1 likely indicates maybe an intrinsic or a post-renal cause. However, this does not fully exclude pre-renal disease. Then you'll want to get labs to calculate a fractionated excretion of sodium or a fractionated excretion of urea, which I'll talk about here in the next few slides. You'll want a urinalysis with microscopic evaluation of the sediment, which may tell you what the underlying disease is. And then you oftentimes want to consider getting a renal ultrasound just to assess the renal size and possibly rule out any post-obstructive causes. So the fractionated excretion of sodium, or FeNA, sounds actually a lot more confusing than what it is. You're basically just trying to determine if the kidney can excrete sodium. That's really all you're trying to do. If the FeNA is high, it indicates that sodium is not being reabsorbed, therefore the problem is likely intrinsic. If the fractionated excretion of sodium is low, it indicates that the nephron is able to reabsorb sodium, so the problem is likely not with the nephron itself. So FeNA basically helps to distinguish pre-renal acute kidney injury from ATN, but this is not absolute. This is just one of those tests that you can do to help try to differentiate what you think is going on. So as mentioned, a FeNA less than 1 suggests pre-renal, but it's not absolute. It can also occur in contrast nephropathy, pigment nephropathy, glomerulonephritis, and early obstruction. A FeNA greater than 1 typically suggests acute tubular necrosis. You must remember, though, this is inaccurate if the patient is on diuretics. With diuretics, you are preventing sodium reabsorption, therefore it is going to be excreted in the urine. so you're going to get a high fractionated excretion of sodium. Therefore, you have to use a substance that is not affected by diuretics. This is where you use the urea. So this is where you would calculate the fractionated excretion of urea, which I won't go into, but you can look at from prior lectures, or you can go to the textbook and find this, or up to date. Just remember that if a patient is on diuretics, you can't use a FENA. It's going to be inaccurate, so you'll use a fractionated excretion of urea. Before I discuss the treatment of acute kidney injury, it's good to look at how you can actually prevent acute kidney injury, which is what you want to do. First is hydration. This is why we typically start IV fluids on most patients admitted to the hospital, and especially those that are scheduled to undergo any surgical procedures or if they're going to receive any IV contrast. Another thing that you can give is N-acetylcysteine or Mucomist, which is used to prevent contrast-induced nephropathy. This is typically given at 600 to 1200 milligrams orally twice a day for 2 to 3 days before they have their contrasted study. The treatment of kidney disease is dependent on whether the patient has acute kidney injury or chronic kidney disease. If they have acute kidney injury, the goal is to restore their renal function back to baseline. So you need to stop all of their nephrotoxic agents. If they're on an ACE inhibitor or diuretics, you typically want to stop these, unless, remember in the heart failure lecture, if you suspect cardiorenal syndrome is the culprit, then diuretics are actually the treatment of choice. Number one thing with acute kidney injury is you have to treat the underlying cause. So you really have to figure out what the underlying cause is so that you know how to treat it. For instance, if it's pre-renal, typically you have to give IV fluids. Whereas if it's obstructive, you just place a Foley. You may have to get urology to consult. You need to relieve the obstruction. If it's intrinsic, this is where it's a little more complicated and you may need a nephrologist to help you manage this. But you have to figure out what the underlying cause is and treat that. Now, if they have chronic kidney disease, your goal is to slow down the decline of renal function. And this is where ACE inhibitors or ARBs are actually warranted, as they treat the hypertension and they decrease the amount of protein that's secreted in the urine. You just need to control diabetes and hyperlipidemia along with treatment of their chronic kidney disease. That will help prevent the decline of their GFR. And you may want to consider placing them on a protein-restricted diet, which is considered 0.7 grams per kilogram per day. You also want to control their salt and potassium intake. Now I'm going to review metabolic acidosis, which you will definitely see on your rotation. Now I'm not going to rehash the basics of ABGs because by now you should already know this, but you may need to go back to prior lectures to review acid-base physiology if this seems foreign to you. Now I'm sure that you guys already know this, but I have had students in the past on clinicals that have gotten confused on this, and I want to make sure that it's very clear. CO2 is bicarbonate on a BMP. So when you're looking at a basic metabolic panel, you're looking at a venous sample. So even though it says carbon dioxide, it actually stands for bicarb. And if you think back to your biochem days, basically carbon dioxide plus water dissociates into carbonic anhydrase, which dissociates into bicarb plus hydrogen ion. So on a venous sample, you're actually looking at bicarbonate when you look at the CO2. The serum bicarb is actually more accurate on a basic metabolic panel than the bicarb you actually get on a blood gas. So remember this, if you want to see the most accurate bicarb possible, you look at the venous sample just under the electrolytes to get the most accurate bicarbonate level. Why is this important? Well, this is basically what's going to help determine the patient's acid-base balance. You can't diagnose acid-base disturbances from an isolated total CO2 because you also need pH and pCO2. However, it does help you determine if a patient has metabolic acidosis. Low levels of bicarb can only mean one of two things, either metabolic acidosis or respiratory alkalosis. If the patient isn't hyperventilating from a panic attack, then more than likely you know the patient has metabolic acidosis. Also, you can't get a metabolic panel without also being able to determine an anion gap. Remember, this is the sodium minus the bicarb plus chloride. This helps you further broaden the underlying cause to figure out exactly what the underlying cause of the metabolic acidosis is. Another note to understand is the difference between acidemia and acidosis. Acidemia means the presence of excess hydrogen in the blood. It reflects a blood pH less than 7.35, and this is what you get on a blood gas. Whereas acidosis means that there's a physiologic process that leads to acidemia. It means that there could be a process present that leads to acidemia. So the pH may be high, low, or normal in acidosis. So if I tell you a patient is acidemic, I am telling you their pH is low. If I tell you the patient is acidotic, I'm telling you some pathology is occurring that could lead to acidemia. This could be due to hypoventilation, like I had already mentioned, like when you get CO2 buildup, or like decay in which acid builds up, or even loss of bicarbonate, like in nausea, vomiting, and diarrhea. So now if you've determined based off lab work that a patient has metabolic acidosis, now it's important to figure out the cause. And there's basically two underlying physiologies. Either they can't excrete hydrogen ion from the kidneys, or they have high hydrogen ion or decreased bicarbonate. And then on the right-hand side are the common symptoms with metabolic acidosis, which you can read through. Now, once you've determined that a patient has metabolic acidosis, that being they have a low bicarbonate level, the next step is to determine an anion gap. This is done with that formula that I told you earlier, but here it is. And then you have to correct the anion gap. So a true anion gap is underestimated in hypoalbuminemia. Remember, albumin is an anion. So the general rule is that for every 1.0 fall in albumin, you increase the anion gap by 2.5. So a normal anion gap should be around 5 to 12. However, it's generally accepted that it's high once it's greater than 15. But this is dependent on whatever lab values you're at. So now that you've determined the anion gap, if the anion gap is high, this is also referred to as anion gap metabolic acidosis, or AGMA. Then you can go to your differential and try to figure out what the underlying cause is. This is where you typically use that mnemonic CAT mud piles, which you'll see on the left-hand side. You can read through this list on your own, but the most important ones are uremia, otherwise known as renal failure, or ketoacidosis, and this can be diabetes related or due to alcohol or starvation, and then lactic acidosis. So think of a septic patient or a significantly ill patient or a patient with ischemic bowel. That could cause lactic acidosis and cause an anion gap metabolic acidosis. So you remember back to the IV fluids lecture along with the hyponatremia lecture that I had you calculate the osmolality. Well, this is taking that one step further. So remember the osmolar gap, which is basically the difference between your calculated osmolality and the lab value of the osmolality. If this is greater than 10, then you need to go fishing for an underlying toxin. This is commonly used in the emergency department to help you determine what toxicity the patient may have, if they're altered or something. So you can take this actually one step further to help widen out your differential or try to discover what the underlying toxicity is. You can do this by adding the anion gap. So depending on if they have a high anion gap, plus they have an osmolar gap, this will help you narrow it down, and you see that section in the middle. Typically, this means that the patient is overdosed on an alcohol such as nail polish remover, isopropyl alcohol, or methanol. Now, if a patient has non-anion gap metabolic acidosis, which means that their anion gap is normal, but their bicarbonate level is low, then this you typically use the mnemonic used carb. A simpler way to look at this, though, if you break these down, is basically due to either GI losses or renal losses, because every single one of these things can be divided into one of those causes. Most of the time, this is actually due to extra chloride, such as the patient getting normal saline, which contains a lot of chloride. But a lot of this is also due to GI causes, such as diarrhea. Now, I know this may seem confusing, but let's just run through a case and see if it makes a little bit more sense to you. So let's say you've got a 62-year-old male with a history of hypertension, hyperlipidemia, history of stroke, and chronic kidney disease stage 3, admitted for nausea, vomiting, and diarrhea, and diffuse sharp abdominal pain. He noticed bright red blood in his stool, and his home meds include lisinopril, hydrochlorothiazide, pravastatin, and metformin. Here are his vitals. You can see he's hypertensive, he's a little tachycardic, his respiratory rate's up. He's afebrile but low grade. His physical exam, he's ill appearing, his lungs are clear to auscultation, his heart is tachycardic but regular rhythm, he has no murmur and no lower extremity edema, so you know he's euvolemic. His abdomen is soft but diffusely tender, and he has normal active bowel sounds. His labs, you can see his white count's elevated, his hemoglobin's normal, his platelets are normal, his sodium is low, chloride's low, his bicarbonate is 15, his glucose is high, creatinine is high, and I put his baseline in there at 1.1, so you can tell this guy has acute kidney injury. His BUN is 52, and his lactate is high. So first off, is this patient sick or not sick? So this patient is definitely very, very sick. So what do you think is going on? So right up front, you can tell this patient has several things going on. He's got leukocytosis, he's got metabolic acidosis, he's got acute kidney injury, and he's got hyperglycemia. So with his metabolic acidosis, what's the next step? So you've got to calculate his anion gap. So for this patient, if you take those numbers and figure out his anion gap, it equals 19. So you know now that this patient has anion gap metabolic acidosis. So this leads you down the cat mud piles mnemonic. So now if you further take his history into consideration, you know that he's got hyperglycemia, you know that he's got lactic acidosis, and you know that he's got uremia. So more than likely, this patient has probable diabetic ketoacidosis, lactic acidosis, and remember his metformin can cause lactic acidosis and uremia. So he's also got hyponatremia, but if you calculate, so his calculated osmolality, 129 times 2, plus glucose, divided by 18, plus BUN divided by 3, so it would be around 300. So this patient has hypertonic hyponatremia. So what causes this? Remember, it's the hyperglycemia, so you've got to correct for the hyperglycemia, and yet that will improve his sodium quite a bit. So on to his renal function. So since his creatinine is greater than 0.3 from his baseline, you know that per KDIGO criteria, he's got acute kidney injury. Also, you could divide his BUN by creatinine to get the BUN to creatinine ratio, and his is 32.5, so he's probably pre-renal. So this guy is dry. He needs IV fluids. So what treatment are you going to give him? So I'll give you a second. So he definitely needs normal saline boluses for and aggressive maintenance fluids on top of that. He probably needs ICU versus progressive care, depending on whatever hospital's protocol you're at. He needs serial BMPs ordered and close monitoring of his vitals. You've got to see when that anion gap closes. That's how you can tell that his DKA is resolving. He also probably needs an insulin drip. You would want to hold his nephrotoxics. In fact, you should just hold all of his medications for now, since he's got nausea and vomiting. And in this patient, I would probably get a stat CT abdomen and pelvis with IV contrast, given his age and other risk factors. Even though his abdominal pain may be due to gastroparesis, you can't really rule out an underlying ischemic or infectious colitis that could be the cause of his DKA. So I would get that CAT scan. But remember, the IV contrast could also hurt his kidneys, so he may need some Mucomist or something also before that, or just aggressive IV fluids at this point. And then I would highly consider getting a GI consult depending on those CT results. So if that was confusing to you, please feel free to ask any questions you might have on the Google document. And here are my sources for this lecture.